Good afternoon, everyone. My name's Darren Smith. I'm a General Manager at University Hospitals Birmingham. I look after the liver units there. But a bit more background, this week marked 10 years in the NHS for me, and I've sort of always been in that coordinating role, operational role into management. And demand and capacity has always formed part of that career. It's followed me. And where Alice is, I think we met about 4 years ago in the original sort of IMAS models down in London. So this isn't something new for me as an operational manager, as a general manager. So what I wanted to do today was really take some of the themes that have already come out in terms of being a bit more proactive and not reactive to the way we manage our services. And I just want to see how many people have heard this or said these phrases, and it's been said on anecdotal evidence. That's how they feel at that moment in time. So, don't have enough capacity, we're breaching RTT cancer, cannot bring patients forward, demand has continued to grow, had a spike in demand, help. And that's how they feel, but they've not had the evidence to back that up, or very limited evidence. And some of that is what Hugh talked about earlier in terms of culture and having the information that's available. But how do we initially react as operational managers and service managers to that? I think the purpose I want to try and get across is a lack of understanding of the cause. We try and push on regardless. And talked about the hamster going on the wheel earlier and carrying on and carrying on. Eventually something has got to give, and it's going to be either performance, retention. Something has got to give if we don't understand what the actual cause of the problems in our services are. And I think there's a level of denial in terms of, we couldn't foresee it. Something new, something extraordinary must have happened. I want to come on to a couple of case studies, one of which is endoscopy, so I won't repeat it because I think Dan excelled on that. But then it's, okay, that firefighting element, what do we do now? How do we, get across line? How do we improve performance? How do we improve patient care ultimately? And that comes to, right, we've got a problem, deal with it, rather than that proactiveness. And I found that picture and I thought, something's happened, and just stood there scratching our heads, and we're trying to push on day in, day out, trying to manage the situation rather than actually plan and understand the cause. And what happens when we firefight? We end up with a lot of short-term measures. Let's have meetings to discuss this. How many of us have been called into performance meetings, regular, give us trajectories of how you're going to improve the service? Well, how can you demonstrate that if you actually don't understand the cause? Can we put more patients into clinics? Let's make that hamster wheel, go quicker. Let's burn the staff out. Is that realistic? I know, let's actually ask for more. So got the same resources. Well, now we're going to put additional resources in. Additional lists, additional clinics, okay? So not only are we putting more pressure into existing resources, we're now putting additional pressure on the same staff to do even more. Well, I've got a few CFOs in today. Let's get locum and agency in. How many people have come in and said, we haven't got enough capacity, back to one of those statements, haven't produced the evidence really or shown that they understand the service, but said the cure is locum and agency. Or perhaps even worse, let's ask others to do it for us. So let's get external people in, or let's move patients to other trusts. That's not the best thing for our patients. We spoke about, ultimately, this is about patient care. If we're asking, if we're outsourcing or insourcing, is that really the right thing for us to do? Let's try and fix it, but we're only fixing it for a short time. And what's the challenges of operationally trying to do that firefighting? It takes up a lot of time. You are ultimately trying to do your day in, day out job, and realising that you're just doing the same thing day in, day out. You're trying to bring those patients forward, you're trying to look at the best use of resources, but you're trying to go to meetings, you're trying to justify what you are trying to do, or you're being called to meetings to say, improve it. Well, that doesn't always work. I think a couple of the speakers have already spoken about estates. There's no space to see extra patients. If you actually plan this and proactively manage it, you can see what your utilisation is, and we've spoken quite well already this morning about utilisation. And at the moment, there's a real lack of willingness to do extra. Staff are burnt out, and we know about the resource gaps. They do not want to do more. The only reason they do in more is because they want to improve the care of their patients. But they burn out, they fall off that wheel. And retention of staff, we lose them. You know, we spoke about endoscopy, Dan spoke about, endoscopy. There's a huge retention issue. And if we keep forcing staff to do more, for sometimes even less, we will not retain staff. But ultimately, when we do extra, it's expensive. It is not efficient. It's not the same as having substantive resources in to manage that demand. And ultimately, it does not address the cause. We have not addressed the cause by any of those. All we've done is firefight and try to put a plaster over. So how can we proactively do demand and capacity? And how does it help you understand the service? Well, for me, it clearly identifies the constraints of the service. And some of that will include seasonality. We know there are some specialties, dermatology, respiratory, breast when there's breast cancer campaigns, bowel cancer for endoscopy, where we know year in, year out, there will be peaks. There'll be some troughs, but if we don't understand that, how can we put the resource in? How can we make sure that we are giving the patients the access in an appropriate time? And it contributes to demonstrating the need for the resource. It's quantitative. It's not that qualitative anecdotal evidence that this is how it feels. It's the other way around, as you said earlier. It's proving how the service feels and going back. And we've spoken earlier about annual planning and the ability to deliver. And a couple of the studies I'll show you, particularly the endoscopy one, talk about growth, year in, year out growth, but there is ad hoc capacity going in. So how realistically are we going to say we're going to put 7, 10, 12% in growth on our income and our activity when we're not even delivering efficiently what we should be doing this year and what we should have done last year? And understands actually how changes could impact the delivery of service. So changes in the modalities, changing in commissioning. Well, actually, you can start planning that in. You can start putting that in. And I found that I hear and I forget, I see and I remember, but I do and I understand. And by doing it, you understand. You understand your services. And for me, as a general manager, how can I realistically come with a business case? How can I go to my director of ops and say, this is what I need, these are the problems, when I actually don't understand the services, I don't understand where the constraints are in that service. So, endoscopy. So, I started in the trust 12 months ago and recently have changed specialties, but when I first arrived, I was managing endoscopy on top of liver, and I'd previously managed endoscopy and used demand and capacity modelling for my previous trust. I walked in, and on day 2, I had a letter from the Joint Advisory Group, JAG, who awards endoscopy awards, accreditation, thank you, saying that our accreditation had been deferred. That was on my second or third day in a new job. And the reason why was there was long-standing failing diagnostics, DMO1. We weren't achieving 2-week waits. While straight to test isn't for part of the JAG accreditation, I think it will be in the next couple of years, certainly. And the referral to treatment RTT position was declining. And they'd had a waiting list that had grown from 700 to 1,300 patients in 12 months. It doubled in size, basically. They were already using waiting list initiatives at weekends, so 2 out of the 4 rooms had waiting list initiatives, additional ad hoc capacity. But they were continuing to decline in performance, and the decision was made, particularly with regards to trying to obtain a JAG accreditation back, because that is a real important for any endoscopy unit, was to bring in an insourcing company. Again, CFOs in the room, how expensive that resource is. More recently, concerns regarding pension and pay, doing WLIs, doing additions. Consultants don't want to do them because they're afraid of the tax bills. It's been well publicised, particularly in the last few months. And guess what? Continued growth expected. We've already spoken about it. It is about anywhere between 6 and 10% in endoscopy growth year on year. And because we weren't particularly doing straight to test, that needed to go on top as well. That was our trend line. So the active core capacity, blue line was the referrals, and the green was the ad hoc, because consistently we were doing 2 rooms every weekend. The line, the previous 12 months was just below the 1,000, and actually since it's gone to about the 2,500. But by proactively, if this had been managed or there'd been a culture of demand and capacity training and that thought process, it was entirely predictable where that line was going. So the demand clearly exceeded capacity, and there's a lack of capacity for adding that straight to test. And it predicts the inability to cope with further growth and growing waiting lists. If we can't cope, look how there was some peaks and that has continued to trend. The business case was written after I arrived on Trust, and we were able to evidence the substantive running of 4 rooms at the weekend. We had the ad hoc capacity, we now had the insourcing company in, and we were looking at different ways of working as well. We know, particularly with gastroenterology, but across multiple medical specialties, there is a lack of consultant cover. And whether that's going to change, possibly not. So we were looking at endoscopy fellows, which some of the London trusts have started using, particularly. Endoscopy nurse practitioners, and the staffing of the nurse. And by clearly giving that quantitative evidence and showing where the growth was going, the business case, which was probably one of the biggest that had been approved, certainly in this financial, well, it would have been the last financial year, was passed first time. It went to divisional directors, and because of the value, it went to board, and it passed first time. Slightly different one for me was HPB surgery, liver surgery. Long-standing failing of RTT. When I started, it was perhaps about the 75-76% mark, and regular long waiters, especially the non-urgent lap cholecystectomies, that were 40+ weeks. We had regular 28-day non-clinical cancellation breaches, so that's patients who were cancelled on the day for various reasons that we couldn't get back in. We just didn't have the capacity to get back in because they were always superseded by the cancer workload. Waiting list initiatives, again, were used in the theatre slots, and regular meetings and trajectories are required. Talking about that firefighting, how are you going to improve this? We had to submit improvements, trajectories to the CCG and specialised commissioning. Again, particularly actually in HPB, there was concerns regarding pension and pay, and it goes back to the job planning that was discussed earlier. And a reduction, but on the flip side of things, and talking about changes in how we run pathways, we have got a Vanguard Centre just started in the last couple of weeks for lap cholecystectomies. So actually that's going to reduce the demand on our service in the liver theatres. So it's about understanding, well, if that demand is now reduced, do I now have enough capacity to deal with the cancer work and the other non-urgent work that will fill into those spaces, and when can I bring that waiting time down? This is the SPC, and the bit I wanted to say, which was similar to the endoscopy one, actually it's pretty consistent. It's a bit ragged, but it's pretty consistent between the quartiles. But available capacity, the core capacity, and what we needed, despite it being consistent for, that was a year and a half's worth of data, so January 18 to July 19, so this is recent data. We still are predicting a huge shortfall. So by being proactive, we could have judged that there was consistent additions to the waiting list. If there'd been a culture of demand and capacity modelling, we would have known last year, the year before, there was insufficient capacity, even with the business case that had gone through for the separate Vanguard theatre to reduce the demand on liver. We had put previous attempts of going back to July. So we had a third theatre that was opened in this period here. And what happened was, it was great, we did more work, we brought down the waiting list, but actually what we did was we flooded the bed base and we flooded ITU. So all that happened was within a few weeks our cancellations just shot up. So it was a very, very short fix, and it worked. Our cancer waiting time went down to 9 days. But poor patient experience. Some of these cancer patients were cancelled once or twice on the day, and that's not great. So we wrote a concept paper last month, which has been approved to progress to a full business case based on the demand and capacity model and the inability to improve performance, therefore inability to improve patient care. The business case in progress has used those models that I've just demonstrated as one of them. We've also got an outpatient and a news and outpatient follow-up model that have done. But the main thing was that demand and capacity model is not the same as doing bed modelling. It's an element of it, and it's an important element of it, and that's the message I want to get across today. But you need, for general managers, operational managers, we need to understand our services inside out, because that's the only way that we are going to improve our patient flow. That's the way that we're going to improve patient care, because it gives us that evidence base. What that happened has allowed me to show that the lack of demand, or the lack of capacity even, and an increase in the demand, therefore, I can map it through to show how much more I want to do, and therefore the impact it's going to have on the bed base and the workforce requirements. If I change my bed base, it's going to have workforce requirements. So in summary, demand and capacity really is important, understanding the constraints. I think everyone that has spoken so far has spoken about the engagement with general managers. For me, it's been the other way around, because I've been the one who's been leading the demand and capacity, and I've been engaging with the clinicians, finance, informatics. It gives clear, quantitative and graphical evidence in supporting service planning. Gone are the days that we should be relying on writing business cases for anecdotal. The service doesn't feel right. We're not performing. Well, why? We need that quantitative evidence. And it allows those without the service base to understand the current and future concerns. Take it to the CFOs, take it to board. They don't understand necessarily the day-to-day running of the HPB service, the endoscopy service. They need to understand how the evidence supports the investment that you're asking them to make. Same with the CCGs. in terms of activity planning, if we go with a 15% increase, is that realistic for us? And is it realistic that we're going to achieve that? But it supports sustainable service by proactively managing that capacity and by efficiently using that capacity, because by doing that process operationally, it means that you go back and look at those pathways, make those changes that can make it more efficient without necessarily asking for the more resource. And it supports the discussions with activity planning and the ability to meet plans. As I said earlier, I always struggle with the fact that we just put a blank growth plan onto any service, but we can't demonstrate that we're even able to achieve this year's plan. Knowledge is power. Thank you. Any questions? As I quickly do.
Thank you very much, Darren. So the one thing that really resonated with me from the service, and that's probably how the NHS is structured, is that we tend to look at our own service, and then we run the models, and we get our own step of the pathway in balance, and then it falls down for the patient at the next step.
So I think understanding the whole pathway is key, and we know that vast majority of pathways go across multiple specialties: diagnostics, surgery, anaesthetics, ITU, bed modelling. And what we don't want to do is focus on a small bit. So what I can show in my service with the knowledge I have about my service is what that pathway is and how we link in. What we have as a trust is quite clear guidance in terms of how we write activity plans and business cases that we link in with the other divisions. Because quite often we'll find is, and I've had experience on both sides of this, is that we forget the support services, for example. So outpatients, that's great. I can recruit my nice consultant. I don't have anywhere to put him, and I don't have any outpatient nurses to support it. So I've got an hour consultant in, but I can't manage my clinics. So I haven't increased my activity, I haven't increased my capacity. So pathway is, the purpose I wanted to try and get across was that the two case studies I presented were that the growth in endoscopy and the gap in HPB was entirely predictable. And if you proactively manage those services and run these models, there will be some specialties it's much more difficult. But there is an element of predictability, and by proactively managing that and understanding your service, it might slow down that hamster wheel. Operationally, the day-to-day running, the hamster wheel never stops. It doesn't. Some things change on a day-to-day basis. We can't plan for everything. But what we can plan for and what we can predict is how the pathways may change, what the impact is going to be, and how can we take that forward in the most efficient and safe manner.
Thank you very much.
No worries, thank you.